Okay, so good evening, one and all. Welcome to the SKIP session 7, which is on a very relevant topic, dental implants, a value-added treatment option. And today we have a renowned speaker, Dr. Segin Chandran, who is oral and maxillofacial surgeon, who is the owner of Kamala Dental Hospital in Trivandrum, and also who is currently the president of the Indian Academy of Facial Aesthetics, Facial Dentistry. Okay, so Doctor, we are extremely proud to have you here on our SKIP platform, okay, which is exclusively for students. Okay, so greatly privileged to have you here. So on this note, let me welcome Dr. Reno Rupak, my department colleague, then Steffi Sargent, the moderator and the for this particular session, and all my third year and final year students to this session. Okay, so now I would like to ask Steffi, you can introduce our speaker of the day.
Thank you, sir. It is indeed a privilege to welcome our speaker today, Dr. Segin Chandran, sir, an eminent oral and maxillofacial surgeon and a well-reputed clinician with more than 20 years of experience in orthodontic surgeries, oral implantology, cosmetic dentistry, laser dentistry, and digital dentistry are his areas of expertise. He was awarded with fellowship and diploma from ICOI. He also holds postgraduate certification in aesthetic dentistry from the School of Dental Medicine, USA. He holds clinical masters in oral implantology from New York University in association with DACE. He's a key opinion leader for Megagen dental implants and Dentsply Sirona digital solutions. We welcome you, sir, to the session.
Very good evening and very welcoming words from our student representative. And let me say a big thanks to my teacher, George Varghese sir, and and all the department heads of your institution, and giving me an opportunity to speak to you young talents, budding dentists of Pushpagiri Dental College. Now, to start with oral implantology, it was one of my passionate subject. As you heard, I had different phases of my career. That was started as a general practitioner, practicing cosmetic dentistry and lasers and implants. Then I moved on to my maxillofacial surgery. Now I practice a mix of dental and surgical practice. I tried my level best to balance these two, and I think it has given me a very good potential solution, and I could give very good solutions to my patients in giving the dentistry in a very aesthetic way and creating good faces with the facial aesthetic surgeries too. And for a maxillofacial surgeon, the dental implantology is not a very major subject, but at the same time for a clinician who is running a practice and who is trying to do his level best with whatever specialty he is holding as a general practitioner. How does this dental implants add value to this in our treatment protocols or in day-to-day practice? That is what our topic for the discussion. Is dental implants a value-added option? So dear friends, now as I think you can see my screen now, is it?
Yes, yes.
Okay. Yeah, that is what I wanted to confirm first. And Dr. Akhilesh is a very good friend of mine. He invited me for this talk, and then Benley and Reno and everyone. Let me thank everyone. And as you are aware, I am working in 2 major hospitals in Trivandrum, then heading a dental hospital. And currently I started as my tenure as president of IACD. And I was into academics for some time too, in a college. And with the blessings from my father and with my all the blessings from my teachers, I could develop a practice that is with all the specialty doctors and very talented young graduates in dentistry. We are running a NABH accredited dental hospital in capital city Trivandrum. And like any one of you, when I started my dental career, I was not very sure about how much I can be successful in this field. And I had no godfathers, or I had no mentors at that point of time. And there was no other member in my family as dentist. Starting from there, in this 22 years, if I could develop my career to this extent, you all studied in good schools and colleges, and with so much of talent, the sky is your limit. To melt down to the basics of dental implantology and to share some thoughts in a very few words within 60 minutes time or another 40 minutes, and I think you all will rejoin for this talk. And I would like to cover some aspects of this implantology. Why do we need dental implants in our practice? Isn't it a very costly option? Why we have to involve in this? Then, how we can select the patients and select the implants? And what are the different implant-based restorations we have? And what are the basic steps in surgery and prosthetic rehabilitation? And just an insight into what we can do when there is no bone. And an insight into, again, to the latest digital protocols in oral implantology. Hope you will be at a receiving side, and let us see why implants. Sorry, I have a bad thought. Now, see this, the name written down in this slide, that is Gordon Christensen. He's a clinical practitioner with different areas of expertise, and he suggested some bottom line principles to be followed in your practice, in sterilization, in clinical diagnosis, in various specialties of dentistry, and he wrote it down and published it as Christensen's bottom lines. So the bottom line of every dental practice nowadays is you should either do implants yourself, otherwise you should have an implantologist in place catering this option in your practice. According to him, if you are not placing and restoring implants in your practice, you will be behind the times. I'm sure every dental student of this era is aware of this fact. And you all are waiting to just get out of the dental school and to start off with your post-graduation or clinical practice or whatever area you are going to be in dentistry. Implantology is an unavoidable treatment scenario. So let us see, what is this dental implant? For the third year students who are just starting with their clinical work, and for the final years. And I think there are some interns. See, dental implant is a structure, or it is a fixture that replaces the root part of your tooth. By this time, you are very well aware that the crown and the root structure of the tooth and how it functions in a groove, like an occlusion or as a jaw with the teeth, and how it aids in the chewing and in swallowing and in speech. In all these functions, that just like any other teeth, we can have an artificial tooth. An artificial tooth in the sense, not without any proprioception, with regaining an awareness of chewing. That means how you're chewing now. Most of you will be having full set of dentition in this generation by this age. When you are in 17, 18, 20s, in your teens, or when you are in your 20s, you will have almost full set of teeth. And if you are taken care, then you will feel the loss of it once you miss one of the molars or one of many of your teeth if you have to replace. That is the time you will think in a very conservative way. How can I replace a tooth without damaging the adjacent teeth or any other vital structures? It is not just a specialty, it is a combination of all the specialties in dentistry, starting from the radiodiagnosis till the surgical aspect and the prosthetic solutions and the functional occlusion concepts. all whatever you learn in this third year and final year subjects, everywhere, this is an option, and it comes in every specialty of dentistry. In all 9 specialties of dentistry, implantology is having a key role to play. Now, you will be learning the basics in your curriculum, but it is my duty to give you an insight in this very brief lecture. As I told you, the function of this implant fixture is to give a fixation into the bone and to hold the tooth in place. So you have to understand, implantology is not placing a screw in and then deciding where to place the tooth. You have to think in a reverse engineering fashion. First, you have to think about what I'm going to replace, whether I'm going to replace a single tooth, whether I'm going to replace multiple number of teeth, or whether I'm going to place the entire jaw, the teeth in the entire jaw, or I'm going to replace the entire dentition, upper and lower teeth. So when you have this question answered, and if you know the medical condition of that particular patient, that is very, very important. Even before selecting the patient, even before selecting the implant, you have to select your patient, whether that particular patient is the right person to receive a dental implant. I will come into that point. So the tooth structure, the crown is there. Though it is fixed at a later stage, it is your primary aim is to see whether you can fix in a tooth in that position, whether there is enough restorative space to hold a tooth there, or the adjacent teeth are tilted, whether the upper teeth are extruded, or we have enough space, the height and width of the edentulous area should be assessed before deciding an implant. Every missing tooth region is not an ideal place to place implants. But in our practice nowadays, it is the secret behind many beautiful smiles. They're smiling with beautiful teeth, beautiful smile, even at the age of their 70s and 80s. And they bless me and go to give them a solution of their desire. They wanted to eat the groundnuts or the chickpeas, what we call the regular hard nuts and cereals. And if they are able to do that, like how they were in their 40s, the results of their happiness after receiving a dental treatment from our office is really worth doing this entire struggle of doing implantology. So why not a bridge? We learn prosthodontics. Now, all the prosthodontic specialty graduates, they learn implants also and come out. We have conservative dentistry where they teach you how to restore the tooth in its form and function, in all its color, shape, size, and all the beauty of giving a natural tooth in look and function. Let me ask you people, if you are having a missing tooth, will you go ahead with having the adjacent teeth reduced or the reshaped and then given with a bridge in place? I'm sure you will hesitate and you will think twice. Now, many times the clinicians give an option of bridge first and implant second because they are not very confident about giving an implant solution because they don't have adequate training or they don't have adequate knowledge about this specialty. Especially in our generation, when we learned dentistry, I passed out in 1999 and I started my practice in 99. I passed out in 98 and I started my practice in 99. That time there was no implantology in our curriculum. I was just mentioning there are some options like this. With 1 or 2 screws, you can place the teeth in. And like many of you, I was most of the time either in the back side of the class or outside. So like we missed many other lessons in dentistry, I missed even this implantology. So, but after starting practice and after knowing the difficulties of a general practitioner to give all the solutions in the right way to the patients, I started searching for an option to learn my general dentistry better. And along with that, I learned implantology, lasers, and all these, the latest generation treatment modalities possible. I'm sure you people are going to be very much getting into this implantology in your later days of your career. Think about this. It is the most conservative way of treating an edentulous span. When you reduce or when you do a crown reduction or a preparation, you are giving the tooth a chance to go for non-vital stage. Though the literature says that around 80% of the crown reduced teeth, if it is done in the ideal way, without going deep into the dentin and without endangering the pulp horns, then you have the survival rate of the pulp vitality around 85%. Most of the times when you don't have adequate knowledge, even in doing that, many times you'll end up in giving inadequate observation, inadequate results in root canal treatments, and most of the times the vital teeth reduction goes for sensitivity and post-op complaints after the tooth preparation and the crown placement. So we have to be very much conservative in our treatment approach, and we have to opt dental implant as one of the choices where you can give predictable results, assessing the bone and giving a solution of a single tooth implant or a multiple teeth if you are trained to. If you don't do that, if you don't advise the patients to get the replacement done in the right time, what happens is our jawbone will go for a resorption. The 70% of the bone reduction, the oleum reduction in a tooth socket happens in the week's time, soon after the extraction. That means if you extract a tooth today, your bone will reduce in its bone and the soft tissues will reduce its oleum almost to 60 to 70% when you take out a tooth that compress the socket and leave it for healing. So what we are landing up is when you have multiple teeth extracted, you get an edentulous span with a horizontal and vertical bone loss. To avoid this, nowadays we do immediate placement of implant. That means we have techniques to place the dental implant soon after the extraction in the same socket. So just like how the extraction socket heals, this implant also get integrated. So the total time taken for the integration of this implant is less. Along with the socket healing, the implants also get integrated. We can have the replacement at the earliest. So now going to, okay. This is what I told you, like if you don't have the right thought process in mind, and if you extract and if you compress the socket, or if you had a lesion in the jawbone, the resulted ridge volume will be very less. So what are the advantages of having a dental implant in place? The first and foremost thing I will say, it preserves the bone around it, and it does not require cutting the adjacent teeth, and they don't develop caries just like any other natural teeth. And with trained hands, I emphasize, with the trained hands, very high long-term success rate, and it regains occlusal awareness, and it increases the stability of the dentures. Every time we don't give fixed solutions with implants, I'll be showing some slides where we replace the teeth in a full arch form with regular dentures, and we retain them into the bone. So it is an option to give extra retention for your dentures, to hold them in place and to give you the function and the aesthetics. And it can reduce the size of the prosthesis. I will go back to this slide. I will say this tooth is indicated for extraction, the number 7, that is 1-7. And he already lost 4, 5, and 6. So what is the edentulous span we are going to get? A long span bridge spanning from canine to that's 7. So that means we are going to have a long span bridge of 6 to 8 units. Such a bridge will have more chances for failure because of its long span. You will learn that in coming days. So going with implant solution, I'll tell you how we reduce the edentulous span. The edentulous span is reduced. Not only that, it avoids the muscular atrophy around the edentulous area. If you have both the sides of molars removed from a mandible, all the musculature connected to the buccal side of the mandible, that is the masseter and the buccinator, all these muscles will resolve, this will show an atrophy, and that will change your facial architecture. So to avoid all these things, the better solution is a dental implant. We always hear this term osseointegration. This is the technique by which the dental implants get fused to bone. I don't want to go into the details of this phenomenon, but you have to understand that there are 2 types of integrations, that is the bone cell getting fused to the implant, or otherwise your soft tissues getting entrapped near to the implant. So when you try to place an implant in an extraction socket or in an edentulous area by doing a drilling and osteotomy, you have to understand, you have to place the implant, and your implant should be surrounded by the natural bone. And if we lack natural bone, we have to graft that area, or otherwise you have to work for some graftless options. In whatever way you place, it should be primarily stable, and it should be surrounded by the bone cells, and it should have a chance to get integrated to bone. If the fixture is not connected in a firm way to the bone, what happens is it shows micro movements. And like any other moving part inside the bone, it will show the fibrous encapsulation. That is why then it will never get a chance to get united to the bone. That is when the implants fail. The failure of implant is because of fibro-osseous integration. So once it is placed with a good primary stability, and it is placed within the bone coverage all around, and with a good soft tissue, it's not only the bone, we should have enough bone and good thickness of soft tissues above the implant, so that it is protected and without any bone loss for a longer time. So let us see the way which we place this implant and give solutions. And let me say, you will have so many myths coming into your mind. The elders would have told, or otherwise whoever had an experience with implants, without proper training and without knowing the know-how of this particular subject, and just like any other person attending any other dental procedures, I will tell a general practitioner, I should say this in the very beginning to you all. When you are getting graduated, you will feel that you're a qualified dentist. And I can do most of the procedures in dentistry. I get so many CVs from the younger generation dentists, and they claim that I can do root canal treatments. I can do this type of procedures. When they come to me and when I ask them the very basic questions, they lack. And if we leave our patients to their hands, and if you ask them to start doing the procedures, what we do, what we get as a result? Failures. It's very much, it is the thing what is going to happen. And you have to understand that any general practitioner can do the dentistry to any great extent if they are well trained. I know BDS graduates practicing endodontics, periodontics, and all the sort of procedures in prosthodontics, and even surgical procedures very well with the good training what they get from their mentors. At the same time, if you start doing this implantology also without proper training, you're bound to make mistakes, and they are not reversible, and they are bound to fail. So And then we have a concept that implants fail most of the times. No, we fail most of the times. Implants are good enough to perform in any bad condition, actually. If you know how to place it in the right way and the right protocols, the failure chances are very, very less. So in refined practice with the proper training, it is a very successful treatment option. I think our screen will shut down after 5 to 7 minutes, and we have to rejoin again. Be prepared for that, please. All the participants, please do come in. Now, I think that, is it okay? Now, I'll go to the few myths what we have about dental implants, that we think that implants don't last for long. They'll just follow after 5 years or 7 years. No. Implantology came into practice almost 50, 60 years back, and they are staying even now. Even the first dental implant placed by Brånemark, it is still functioning well. So why we are worried about the longevity? So, and any titanium screw milled and placed in bone will have the longevity, and it will get fused to bone, and it can retain for longer years, almost the lifetime of the patient. Oh, this is a best forensic evidence nowadays. The implants last even after the person, even that person's demise. So are they very expensive? I will say no. If you don't mess up implantology, if you practice on system with its right components and the right fixtures, and if you select your implants in the right way and give a solution, and if you don't have to repeat that for the patient at no cost, implantology is not very expensive. It is much less than you giving a long span bridge, multiple root canal treatments, and giving zirconia-based restorations. It is much cheaper than this type of treatments what we offer. Are they very painful? I will say an implantology practitioner should have good skills of an RCT and the surgical skills of a oral surgeon. If you have these two skills in your hand, you can very well start off with your implantology. If you know if your hand is highly, tuned to handle the measurements in micromillimeters, like how we do a root canal treatment, to go to the depth in millimeter by millimeter, and if needed to open up that area's flap and to do a grafting, or to see what is happening with that particular implant, if you know how to raise a full thickness periosteal flap, and you can have an access to that bone and see. And if you have the armamentarium to have a good surgical procedures, then you are very well ripe enough to start practicing dental implantology. I think
it's 4:30.
Our time is getting short for this session. Bentley, is it time to stop or shall I continue?
Okay. I think we'll just restart soon.
Yeah.
Yeah.
When it is time, you will prompt me, right?
Yeah.
Okay. This was the scientist. He was an orthopedician, Brånemark from Sweden. He placed the first dental implants. Even much before his time, scientists knew that this titanium is having a tendency to get adhered to the bone cells. Even in 1940s, even much before we all were born. That is the time of our parents. That is the time we know that this metal is having such an affinity. And later, it was Brånemark, an orthopedician, who gave a tooth fixed with a titanium screw to one of his, not his patient, an orthopedic patient's driver who came to drop him in his practice. He called him and told, hey, you have a missing tooth, shall I place a tooth for you? And he placed a dental implant, and later he restored it with a crown above that. That was the first dental implant. So then we had, even after that, we had so many designs like blade implants, cylindrical implants, then basal implants, screw type implants, then basket type implants. There are many, many designs of framework and the screws and plates what we had in the ancient time to fix up a natural tooth over it. So the Brainomarx implants were very cylindrical, and it was a type called as external hex. The connection was above the implant platform. And now it has changed to more of a root form. And there are single piece implants available for very less edentulous spaces, like when the space is very less, or you don't have to wait for a longer time to load it. There are special indications for that single piece implants. And now we have very latest advancements like zirconia implants. I had an opportunity to use a few of them when I was practicing with one of my senior person in Mumbai. And even now, the connection between the superficial structure called as abutment and the fixture is titanium. And these materials are little brittle, and it works out best in the hands of the best trained clinicians and good surgeons. But it is having an advantage of being highly aesthetic. It doesn't, and when zirconia is having the same properties of titanium in terms of its affinity to bone cells and getting the osseointegration. So we have an option to place the superficial part, the superficial structure above the dental implant with the zirconia, so that the aesthetics is not compromised. As I told you, we have a fixture and an abutment and a screw connecting these two. So surgically, you will be placing the dental implant in position. Then later, you will be attaching an abutment above that will receive a crown at a later stage. I don't want to go into the different types of dental implants now. I will say one word about the implant surface. When we place a bioactive metallic object in the bone, it will give signal to the bone saying that a similar object is near to me. So it is just fooling the biological tissues around. So we create a surface that is same like that of the lattice network and the what we call the inorganic components of bone, the trabeculate pattern of bone and the calcified structure in a bone is mimicked in the dental implant with the same microstructure that of bone. So the surface porosity of the surface roughness in a dental implant is same like that of a frosted bone. And that is why these dental implants are accepted very fast by the host cells and the host tissue. Now, I don't want to go to the different surface treatments and the different types of dental implants, but there are more than 2,000 dental implant companies in this world.
Yeah, Dr. Second, we'll restart.
Yeah.
Yeah, okay, fine.